You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for April 15th, 2022. This week, a little bit more from the ACC, ventricular tachycardia ablation, heart failure, triple vessel coronary disease, and a doozy. So 2 small randomized controlled trials published recently got the EP community excited about quote-unquote early VT ablation. Both of these trials had top-line positive results, but while I love RCTs and I wish medicine did more of them, these 2 studies should not change our cautious approach to VT ablation. There are just too many limitations in these papers. As background, I'm going to discuss VT ablation in patients with substantial structural heart disease, which is usually ischemic. This differs a lot from ablating VT in normal hearts, which is less risky and often curative, similar to SVT. For the non-cardiologist out there, scar in the heart provides the 3 components of reentry tachycardia. That is, multiple pathways, unidirectional block in one pathway, and slowed conduction in another. Think of a scar with many different channels of surviving myocardium that can act as these different pathways. And ablating VT in patients with structural heart disease, however, confers added risk because patients usually have systolic dysfunction. They may not tolerate their VT very well. These prolonged procedures with saline irrigated catheters can lead to heart failure. And of course, stroke is also a significant possibility given these dilated ventricles. That said, ICD shocks from VT are certainly a bad thing. They hurt and can cause PSD. Shocks associate with worse prognosis. And so preventing a patient with an ICD from getting a shock or having more shocks is definitely a good goal. All right, first trial is called Partita. And at ACC, Professor Paolo Della Bella presented results of the Partita trial. Circulation simultaneously published the paper. Now, Partita was billed as a 2-phase trial, but it is really just a very small trial comparing VT ablation in patients who received the shock versus continuation of standard care. Phase A, as the authors called it, involved about 500 patients who had an ICD placed, and of these 500, 11% or 56% of the patients received an ICD shock for VT. 47 patients agreed to be randomized to ablation versus standard of care. That is right, 23 in the ablation arm, 24 in the standard arm, and 18 of the 23 got ablated in the ablation arm, 18 patients. Now, the primary endpoint had nothing to do with ventricular tachycardia. It was instead a composite of death from any cause or hospitalization for worsening of heart failure. So right off the bat, you should be thinking, wait, VT ablation is a therapy designed to reduce VT or stop ICD shocks. Would we not want to measure that? But after 2 years, the primary endpoint occurred in 1 of 23, 4% of patients in the ablation group versus 10 of 24, or 42% of patients in the control group. So the hazard ratio was a whopping 0.11, or an 89% reduction. But here's the problem. Because of these small numbers, the 95% confidence interval ranged from a 99% benefit to a 15% benefit. And the p-value squeaked under the threshold at 0.034. There were 0 deaths in the ablation arm and 8 deaths in the standard of care arm. This drove the composite endpoint. Heart failure hospitalizations were lower in the ablation arm, but it was not significant. The big difference was death. But here's the thing. Cardiac death recurrent VT, VT that required anti-tachycardia pacing, or VT that required shocks, those rates did not differ in the two groups. So you might wonder how a procedure that reduces VT or cardiac death drives overall mortality. And I did too. So I went to the supplement. Always go to the supplement. Here they listed the causes of the deaths. And there were 8 deaths in the standard care arm. 1 for skin cancer, 1 for sarcoma, 2 listed as non-cardiac, and 1 for sepsis. So that's 5 of the 8 primary mortality events driving the difference had absolutely no relation to the ablation. Now, you don't have to be a statistics expert to know that taking 5 events out of the standard arm would have made this a non-significant finding. Also, it seems strange that there were 0 deaths in the ablation arm. Think about this. It's a population of ICD patients, EF 32%, mean age 72. With or without VT, with or without ablation, you would not expect 100% of patients to survive for 2 years. Now, that isn't nefarious. It simply highlights the problem with small numbers. Finally, another peculiarity, the authors report 0 complications in the ablation arm, which differs substantially from the next VT study that I'm going to tell you about. The authors write that, quote, Partita provides evidence that catheter ablation should be considered after the first ICD shock in patients with cardiomyopathy. No, I don't think so. But let's go to the second VT ablation trial. Jack published the Survive VT trial from multiple centers in Spain. This trial compared VT ablation using substrate-based ablation or antiarrhythmic drugs in patients who had ischemic cardiomyopathy who had an ICD shock. A brief word on substrate ablation. This means we identify the scar tissue in the heart and ablate all late or fractionated potentials in that scar. There is not an attempt to induce or map one or more of the specific tachycardias. Some have called this, quote, homogenation of the scar. The idea is that by ablating the entire scar, you ablate all the possible channels for reentry. The Survive VT had more patients, 144 patients, similar kind of characteristics, age 70, mean EF 35. Now again, we get this curious endpoint. VT or recurrent ICD shocks is not the only endpoint. Instead, the authors choose a composite primary outcome of CV death, appropriate ICD shocks, unplanned hospitalizations for heart failure, or severe treatment-related complications. Now, it's that latter component, severe treatment-related complications, where the issue is going to come into play. So here are the results. Overall, the primary outcome occurred in 28% of patients in the ablation group versus 46% of those in the antiarrhythmic drug group. That hazard ratio 0.52. Confidence intervals goes from 0.3 to 0.9 and a p-value 0.021. So boom, it's positive. But let's look at the 4 components of the primary outcome. Let's see what drove the results. Cardiovascular death was the first component. There were 3 in each arm, no difference. Appropriate ICD shocks, 12 versus 13, so no difference. Heart failure hospitalizations, 8 versus 13 in each arm, so again, no significant difference. The positive primary endpoint was driven by severe treatment-related complications, 7 versus 21 in the ablation versus drugs arm. So what are these treatment-related complications? Well, in the antiarrhythmic drug arm, here are some examples of the severe issues. Sinus bradycardia in 2 patients, dyspnea in another, low thyroid in another. Many of the other severe events were slower VTs that required hospital admission and subsequent ablation. Now, also of note, in Survive VT, there were 10 major complications in the ablation arm, and 10 of the 71 patients in that group calculates to a 14% rate of major complications. Keep in mind, too, that this is the rate in the confines of a carefully controlled trial with sites selected for their skilled operators. Surely it would be higher out there in the real world. Now, some of the secondary outcomes are also very interesting. Of note, total mortality, appropriate ICD therapies, and any documented VT, the rates of all those were similar in the 2 groups. The authors concluded that in ICD patients with ischemic cardiomyopathy and symptomatic VT, ablation reduced this composite endpoint, and they write in the discussion, quote, based on these results, catheter ablation should be strongly considered before antiarrhythmic drugs as a first-line strategy for patients with ischemic cardiomyopathy and ventricular arrhythmias. Gosh, I just don't think so. If VT ablation works, it's supposed to stop VT, which then reduces ICD shocks and CV death, and this is not what happened. In SURVIVE, appropriate ICD shocks, CV death, total death, and VT were all similar. Note that a much stronger VT ablation trial called VANISH, which enrolled 260 patients who had VT despite taking antiarrhythmic drugs. Here, the choice of therapy was giving more antiarrhythmic drugs versus ablation, and ablation barely proved beneficial in that bigger trial with a p-value of 0.04. And in the supplement of SURVIVE, the authors report results of their trial using the endpoint that was used in the VANISH trial, the stronger trial, which was death, more than 3 episodes of VT within 24 hours, so-called VT storm, or appropriate ICD shocks. And if they used the VANISH endpoint, SURVIVE was null. So technically, the SURVIVE trial was a positive trial, but it had a 14% rate of major procedural complications and was driven by a dubious endpoint of serious treatment-related complications. And I say dubious because A, it wasn't a blinded trial and it's done at ablation centers. There's likely a performance bias. B, sinus bradycardia, dyspnea, and low thyroid in an amiodarone patient are hardly severe complications. And of course, C, you'd expect more incidences of slow VTs in the antiarrhythmic drug arm. That's okay. That's not a severe complication. This is what antiarrhythmic drugs do. If the patient has a slow VT and is symptomatic, it can then be ablated. Many patients don't get slow VTs on antiarrhythmic drugs, especially after having just one shock. And what's more, and this worries me a lot, SURVIVE authors don't tell us how many patients they screened over 7 years in 9 centers to get to these 145 patients. It makes you wonder how representative these patients are to the average patient who gets an ICD shock in regular real-world clinical practice. And finally, going back to Partita has 20-ish patients in each arm, and the results are driven by non-cardiac deaths. So, in sum, VT ablation has a role in the treatment of patients with significant scar-related heart disease, and I do VT ablation, and it can be very rewarding. But it is the most hazardous procedure we EP docs do. It deserves high doses of caution, and neither Partita nor SURVIVE suggest we be more aggressive with this complicated and risky procedure. All right, next topic. How about alerts for heart failure care? One of the biggest issues with the care of patients with heart failure is getting patients on the 4 guideline-directed tablets and getting the doses titrated to the best possible dose. This is a job for the outpatient clinic, and everyone who has practiced in an outpatient clinic knows it is a busy place. There is inertia to mess with medications. Messing with medications creates extra work, and extra work means running late, and that may mean getting home later. Now, of course, clinicians want to do the best by their patients, but clinicians are also human. We don't have an endless supply of energy. Well, an energetic, seemingly tireless research group at Yale is interested in the implementation process. They presented their latest work at ACC, and Jack published the PROMPT-HF trial, PROMPT-HF. This was a pragmatic, cluster randomized trial of 100 clinicians. They used the term provider, but I can't get myself to say that awful word. Recall that cluster randomized trials randomizes clinicians, not patients. Here, one group of clinicians got the EHR, electronic health record alerts, and the others did not. Now, the alert notified clinicians of GDMT recommendations. The primary endpoint of PROMPT-HF was simple. It's an increase in the number of GDMT classes of drugs prescribed at 30 days. And the EHR alert seemed to work. The primary endpoint occurred in 26% in the alert arm versus 19% in the usual care arm, increasing the class prescription by approximately 40% after the alert exposure. The adjusted relative risk was 1.41 and the p-value 0.03. Nearly 80% of the alerted providers agreed that the alert was effective at enabling improved prescription of medical therapy for heart failure. Okay, my comments. Prompt HF is kind of an outlier. Most efforts at improving quality have not worked. The authors cite at least 4 earlier studies that have failed to show any benefit from alerts or QI measures in terms of outcomes, and even one of them was from their group. Now, perhaps this EHR alert worked because it was simple and it was the only alert clinicians got. Perhaps it worked because it was designed with clinician influence. Perhaps it worked because it was only in the outpatient system. And of course, there are limitations here. The trial was done in one system of academic centers, and the Yale authors seem like serious champions. EHR alerts without sort of champions like this might not have such an effect. But this is a start. I really, really like this work. Of course, it is important to try and improve systems of implementation. But what really excites me about the Yale group is that they are studying these efforts empirically. This cannot be understated. Empirical study of policy may be more important than drugs or devices. I mean, so much of the quality movement has simply been foisted on clinicians because it made sense, at least to policy wonks. This week, my friend Lisa Rosenbaum, the national correspondent for the New England Journal of Medicine, wrote a brilliant piece titled Reassessing Quality Assessment, the Flawed System for Fixing a Flawed System. I will link to this in the show notes, and it is a must-read. Now, had we hewed to the Yale's team's approach, empirical study first, to implementation of policies, we might not have had such a flawed quality system that has now metastasized into gigantic rent-seeking bureaucracies which distract caregivers from delivering care whilst draining immense value from the U.S. healthcare system. All right, next topic is triple vessel coronary artery disease care. The FAME-3 investigators are back, and they presented a sub-study of their main trial at the ACC meeting, and Circulation simultaneously published the results. Now, it's a head shaker, and I'm going to try to remain measured. Now, recall that the original FAME-3 trial tested non-inferiority of FFR-guided PCI versus CABG in patients who had 3-vessel coronary artery disease. Now, the results of the primary endpoint of major adverse or cerebrovascular events defined as death, MI, stroke, or repeat revascularizations were decisive. The 1-year incidence in FAME-3 of the primary endpoint was 10.6% in the FFR group, 6.9% in CABG. The hazard ratio was 1.5. That's 50% worse. And the confidence interval's upper bound went to 2.2. So an upper bound of 2.2 means that the FFR PCI group could be up to 2 times worse than CABG. And that did not even come close to meeting the non-inferiority margin. Now, these words sound funny, so I'll say them slowly. FFR-guided PCI was clearly not non-inferior to CABG. Okay, now the authors are back with a sub-analysis looking at quality of life as measured by a European Quality of Life 5 Dimensions questionnaire. And the results at 1 year were nearly identical, no difference. But then the authors tell us, quote, the trajectory of quality of life differed. PCI quality of life was better at 1 month. But, my friends, this is like saying you will get wet riding a bike in the rain. Of course, CABG has a tougher short-term recovery. Everyone knows this. Now, the other secondary finding of this study is that the proportion of patients who have class 2 or greater angina at 1 year was, get this, 6.2% in PCI, 3.1% in CABG. The odds ratio turned out to be 2.5, so more than 2 times greater chance of having significant angina in the PCI group. However, the authors conclude, quote, the rate of significant angina was low in both groups and not significantly different. And that is, of course, because the confidence intervals of that 2.5 times odds ratio that was worse for PCI went from 0.96 to 6.8. So the bulk of that confidence interval is greater than 1. Now, the take from the investigators was that this data primarily the faster recovery from PCI might be important for shared decision making. But here's another take, my take. If you choose FFR PCI over CABG, you will have a higher rate of major adverse cardiac outcomes, no difference in quality of life at 12 months, and a 2.5 higher odds of class 2 angina at 1 year. I don't understand. Why can't we just accept that CABG is the better strategy for patients with 3-vessel disease? The FAME-3 trial confirmed the results of Syntax, which was done a decade before. My gosh, that this sort of post hoc analysis gets in circulation, it gets spun as a new twist, is disheartening. I mean, PCI and its iterations are awesome. It has utterly transformed cardiology in the care of patients with ACS and acute MI, and I don't understand why this isn't good enough. All right, last topic. Speaking of disheartening, I have to tell you about the story of the Diamond trial of a drug called patiromer. This was a late breaker at ACC. There's not yet a paper. Patiromer is a novel potassium binder that is used to lower potassium levels and maintain normal potassium levels. The Diamond trial was designed to assess whether patiromer in patients with heart failure with reduced ejection fraction who have a current or a history of hyperkalemia due to RAS therapy, renin-angiotensin system inhibitor therapy, can simultaneously control potassium levels and therefore enable RAS therapy, which would then lead to improved clinical outcomes. Now, as background, before I tell you anything, I looked it up. A 30-day supply of the drug retails for about $1,000. So the Diamond trial enrolled symptomatic patients who had heart failure with reduced ejection fraction and hyperkalemia or a history of hyperkalemia while on RAS inhibitors, which then led to a dose reduction or discontinuation of the drugs. Now, since the trial was treating patients with serious illness, and the drug is designed to allow patients to stay on life-saving drugs, the RAS inhibitors, the trialists set out to show patiromer reduced CV death or hospitalization. This is an excellent outcome choice. But alas, the investigators changed the endpoint to get this, change in serum potassium levels. Now, after randomizing about 400 patients per group, the primary endpoint was found to be significantly better in the patiromer arm. The p-value was less than 0.001. This sounds great, right? A big win. Well, your next question should be, okay, Mandrola, what was the effect size? The answer? The change in potassium was 0.10. Yes, I said that right. The $1,000 per month drug, which is used to treat an adverse effect from another drug, reduced the potassium levels by 0.1, like 5.0 to 4.9 potassium. CV death was now a secondary endpoint, and they showed absolutely no difference. This led to the final bullet point from the slide. Quote, these data suggest the potential for improved outcomes with patiromer-enabled optimization of GDMT in patients who are unable to tolerate optimal RAS treatment due to hyperkalemia. The press release from ACC gushed positive results, and the PI of the trial told journalist Steve Stiles, quote, it stands to reason that optimization of RAS inhibitor therapy without a concomitant risk of hyperkalemia may, in the long run, lead to better outcomes for these patients. So my comments. This reads like something out of the house of God. A drug creates an adverse effect, and we give another drug to treat the side effect. Then, the pharma-sponsored trial changes a real endpoint to a Mickey Mouse endpoint guaranteed to be positive. I mean, this would be like measuring blood pressure increase with dopamine. The drug is designed to lower potassium levels. Of course it lowers potassium levels. Then the p-value is super positive, but the effect size is literally minuscule. I can only hope that when this paper comes out, someone brave writes a strong editorial. And finally, I'm not saying that a potassium sequestering agent is useless, but come on, patients with heart failure already have to take tons of pills, and if you want me to prescribe a drug to treat another drug's side effect, you have to show me outcomes data. So that's it for this week in cardiology. As always, I'm grateful that you listened. And remember, please, friends, if you like this podcast, it really, really helps to give us a rating, write us a brief review. These kinds of things help others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.